for coming out here on a Saturday to listen to some science. I'm a professor at the University of Louisville in the neurosurgery department, and you probably hear my accent right away. If I need to slow down, let me know. I'm used to it, but I will give you a little intro where I came from and how I ended up here. I share a lab with a neurosurgeon who treats Parkinson's disease with deep brain stimulation treatment. So he is the surgeon to implant the deep brain stimulation devices, and we share a lab together. I do most of the research and come into the cases where he does the actual surgery. And we are interested in understanding cognitive function in relation to how the brain operates. So when is the brain engaged in certain cognitive functions, and how does that change when things change with diseases like Parkinson's disease or other movement disorders. Now, how did I end up in Louisville, Kentucky? I have a background in cognitive neuroscience, so not in neurology or neurosurgery, a research background. And during my PhD, I started collaborating with a neuropsychologist in Virginia, the University of Virginia. That collaboration turned into a position at Vanderbilt University. That's where I met Dr. Joseph Lehmann, and I ended up here in Louisville. And in between, in Nashville, Tennessee, I met my husband. We had 3 kids, and I'm still here. I did not expect to stay in the US for this long. I'm originally from the Netherlands. But it's been good. And you'll hear about my research today, so I'll share some of them. So I will review some of the exciting, or I think exciting, neuromodulation advances that there are in DBS devices and some other things that are going on. Work that we are doing specifically in my lab in collaboration with Dr. Niemann and with the whole movement disorders team. So the neurologists collaborate with as well. Neuropsychologists, and I don't know how many of you here are familiar with the doctors at Louisville, or maybe you received your care elsewhere, but if I'm throwing out names, for some of you that may be familiar, but for others not. But the whole movement disorders team is engaged in this research. And I will, at the end, I will cover some of the benefits of exercise, and because I know this is a very engaged group in exercise, and everybody's interested in it, and how that can help you with cognitive function, or which cognitive functions particularly benefit from exercise. So, sorry. As you are aware of, changes with Parkinson's disease is largely due to the loss of dopaminergic cells. Now, this is very impactful on your movement and in how to regulate your actions. But dopamine actually has a role in a lot of different functions, not just movement. So there are changes that happen when there are changes in dopamine due to Parkinson's disease that happen across a wide range of circuits. So not only the motor circuit, but also cognitive and limbic circuits. And what that means is that some cognitive functions, thinking skills, may change because there are changes in dopamine. It doesn't regulate it as well. It might slow it down, or it might make certain cognitive functions harder, like, for example, keeping a grocery list in your mind, or quickly adjusting when some plans change. For example, if you think about the traffic going on right now downtown, if you're used to going your regular automatic mode route from place A to B, and suddenly you have to veer around and think and adjust, those kind of skills may be harder, or may slow you down a little bit. And then also the circuit involved in emotions and feelings are impacted. And I think Dr. Underwood gave a talk here a couple of months ago, so maybe he covered some of this. But yeah, I hope it's not redundant, but he may have covered some of this as well. Because he looks particularly into those cognitive and affective functions, whereas the neurologists really look into the motor circuit. So the motor symptoms you're all, I'm sure, very well aware of. And those are the main focus of the neurologists in terms of treatment. So the treatments that are out there are very much focused on helping you improve those motor functions, making sure that those are addressed. And the medication does a pretty good job, and the DBS can help, but some symptoms are not as well addressed with the current treatments, or they're not covered at all as much, like things like non-motor symptoms such as sleep, mood, and cognition. So those other circuits that I showed outside of the motor circuit are not the main part of the current medical practice to address those. So what I'm particularly interested in my lab is understanding those cognitive functions. How do they change? What can we do with our existing therapies? How can we modify them to actually address some of these cognitive functions so we can make it better, or we can address the issues that are existing either as a result of Parkinson's disease or sometimes as a side effect of the medication? Can we optimize it so it's not only the motor, but it's the whole person that's being addressed? And sometimes neurologists are not the ones in our training necessarily, but sometimes they get, when we get a grant review back, they're like, well, why is this important? We're treating them, we're making them walk again, and it's all good. Why is this important? Well, think back of the times when there was COVID and the post-COVID symptoms that people described, the brain fog and not being able to think. That was really detrimental, and a lot of people complained about it. It's that ability to be able to focus on something and then adjust when things change, keeping things in your mind. All those functions are very important for your daily life, for communication, for financial decision making, for caring for others. So I think they're very important, and I will be talking about it more and sharing some of the work that we're doing and how we can hopefully leverage the existing treatments to also address these functions. So treatments, standard treatments are, or default treatments are dopaminergic medications. I don't know how many of you have heard about DBS, deep brain stimulation, or have experienced, or may even have one here. But I will, that's usually not the first treatment that the doctor will recommend. First you would start with medications, and if that doesn't work, then deep brain stimulation is often discussed or offered depending on what would benefit you most. And I will show you an example. So some of you may already be familiar with the deep brain stimulation, but for those who are not, it's in a sense, it's you can think of it as a pacemaker for the brain. So it provides electrical stimulation through an electrode that's implanted into the brain by the surgeon. Provides continuous stimulation at a particular frequency, high frequency of 130 hertz, so very good high burst of stimulation. It's really effective for motor symptoms. A lot of people can significantly drop their medication, so they don't have those fluctuations in the medication anymore, which can be really beneficial. But the original traditional DBS, how it was initially developed, is not sensitive to changes over time or changes that happen in your life while you're moving. So sometimes you may need something else, like when you're sleeping, for example, you might not need as much stimulation. Or when you're sitting down and having a conversation, you may need something different than when you're trying to get up and run around or do your groceries. So it doesn't have that real-time precision, the traditional DBS. And it's not optimized for those non-motor symptoms, like cognitive function, like sleep, like mood. So that was not how it was developed. It was really for the clinical motor symptoms. But there are quite a bit of new developments in these devices, and these are not only in the field of Parkinson's disease, but also in, for example, epilepsy, to treat epilepsy. The new devices can actually measure your brain activity. So it's not only stimulating, but it can also, the electrodes can measure your brain activity and respond to that. So it's more adaptive to what's going on in your brain. And that can be leveraged to more optimally stimulate when you really need it, when your brain is low on a certain brain activity. And there are more electrodes within each contact point. And I'll show an example. Well, this is an example. So that helps us direct the stimulation in a certain way. And I'll go into detail with that. So the adaptive DBS devices, they can adjust the stimulation dynamically based on what's going on in your brain. Again, this is very much optimized for addressing your motor symptoms. So the research has focused on finding a biomarker for those motor symptoms. So when you're, for example, freeze, or when you have a harder time initiating an action, there's a particular brain activity that is increased, and the DBS helps reduce that. So when that is very high, that's when your stimulation would ramp up a bit. And when it's kind of normalizes, it might go down. So it's more efficiently regulating your stimulation. Although it's not currently used for cognitive symptoms or for mood, it definitely has that potential, but we would need to find the correct biomarker to respond to, and deciding what kind of adjustments do we make when you're want to have, for example, a conversation. Now you might not need to move around a lot. Maybe you really need those cognitive skills. You're driving, you're having a conversation, you're making financial planning. Then you might want to focus on those cognitive skills. And it does have that ability now to target those if we have the right biomarker for it. And that's what part of my lab's work is looking into. And on top of that, because we have those leads with multiple contact points, the stimulation can be directed towards different networks in the brain. So remember earlier, I showed you these motor and cognitive or mood networks. If you can direct the stimulation to one particular network, that would also help targeting really specific circuits. So this can be much more adapted to an individual's needs in terms of motor and cognition and mood. So we can stimulate, with this technology, we can stimulate different circuits and different functions. This is not only used for Parkinson's disease, but also currently for mood disorders like depression. It's used for obsessive compulsive disorder. So there's a wide range of use for DBS. It's not in the same brain areas as what we're doing for Parkinson's disease, but the stimulation technique itself and the use of this technology is used across a wider population. And that's really a development from the last 10 years. And it's very exciting, I think, for some particular treatment-resistant depression. There's really no good solution for it, and this seems to work fairly well. So that's exciting. And this also illustrates that it does really have that potential to modulate other things than motor symptoms. So regarding what we're doing in my lab, I already alluded to it a little bit. We're interested in what kind of brain activity do we see when you have these challenging cognitive demands in your environment. How can we measure those, and how can we find a potential biomarker and then adjust our stimulation to that? And we were also interested in the brain circuitry related to changes in mood and something like apathy, and I'll go into detail with that as well. So how do we study the brain and cognitive function? It's it's obviously because it is a lab, it's not as realistic as what you would encounter in your, or as demanding as what you would encounter in your daily life. But we, one of the things we do is we record the brain activity while patients undergo deep brain stimulation surgery. So for those who are able to do it and willing to help with the research, we ask them, are you willing during the part of the surgery that you are awake, because that is part of the clinical procedure to find the best spot for the motor outcomes. The surgeon does that anyways. Are you willing to play a computer game with us? And we actually had a lot of people help us out with that. They were very brave. They came out of anesthesia for the mapping with the surgeon and then played the game with us. And you can see some examples here that somebody in the OR looking at the screen, they're pressing buttons in response to some of these computer games. And what we can do, we can connect that to the brain activity afterwards and analyze the signals that are related to the choices a person makes. So they can press a button and then we can look, okay, when they pressed the button, this part of the brain area was firing, or maybe it was not firing. So we get a really good sense of what's going on, and especially when the task is hard, and I'll explain that in a minute, like what can make this task hard. And we also use assessments that you might be familiar with from the neuropsychology clinic. If you have been there, I don't know if you had an assessment with a neuropsychologist, but they often use assessments, questionnaires, or they use assessments where they make you make little drawings or memorize things for a brief period. Those are less time sensitive, they look more at the broader scale. What we're using in the lab is mostly the very fast-paced cognitive skills. But we do look at some of the questionnaires and the subjective assessments as well. So this is an example of our setup, or more detailed setup. We measure in a, I don't know if the mouse is going to show up when I move over. I can show you here. So this particular, that's the subthalamic nucleus. It's a very, very small target for deep brain stimulation. It's not the only target, but that's one of the targets that's being used to stimulate and implant an electrode. During the surgery, we can, the electrodes are in there, and we can measure brain activity in relation to that task, because it's all connected in one big setup. So here's an example of the size of the STN. It's really small. It's only a couple millimeters. This is obviously enlarged, and you can see how small the electrode is. This is the implanted electrode that will stay in the brain, and this is what we use during the intraoperative measurement. So it's tiny, tiny, but it's really good at picking up activity from individual cells or from groups of cells. So we were interested in what kind of activity do we find in this particular brain region, this region where we know it's involved in regulating motor, initiating actions or suppressing actions. What do we see when you have to inhibit kind of an automatic response? And I'll introduce this task. So we ask our participants, when you see these colored circles on the screen, when it's green, you press right, but when it's blue, you press left, regardless of where it's presented. Now, if you see the green circle on the left, and if you try to do it, it's much harder to respond with your right hand when you see something on the left, or vice versa, when circle moves to the other side. And in those challenging situations where the locations or the information from your environment does not match up with your goal, what you're intending to do, which happens a lot in our daily life, where you think of something, but there's a lot going on and you need to adjust. So those specific situations where it's hard, that's what we're interested in. What do we see in the brain when you're challenged like that? In a tiny, small version of reality in this game. So what we did find is that the brain activity in the subthalamus nucleus, so this particular nucleus in the brain involved in motor circuits, is also involved in regulating these actions. So it's more active in these situations where you're challenged compared to when you're less challenged. So that could be a really interesting biomarker for our potentially for adaptive DBS. So one of the next steps that we're hoping to do is use this adaptive DBS and use this particular signal that we know now is relevant to adjust during cognitive task performance. So that will be one of our next steps to look at that. So it may optimize the DBS towards cognitive function. And this particular function is not only relevant for this particular game, but it plays a role in many different other cognitive demands. And it gives us also insight into how does the brain in general work in regulating action impulses. But that was more of the broader science approach. So that's one study. We've also had, to give you a broader idea of the context, we've also had studies where we stimulated in the region and saw how that impacted the particular game, which does have an impact as well. So we know now from both the measurements, the brain activity, as well as the stimulation, that this is a very important structure for cognition. Another study that it's ongoing still. One of the graduate students was interested in apathy and feelings of apathy or lack of drive. It happens a lot in Parkinson's disease in general, but based on the literature, it can change with DBS. Some people report more apathy with deep brain stimulation. So we were interested in, can we understand what kind of networks are involved with that when we stimulate in the brain, and are there maybe networks to avoid, or maybe others that we should stimulate on top of the motor networks to make it a little better. And so far we've collected, or we've asked patients to assess their apathy before surgery and after surgery, so say at least 6 months after, in patients that either had their electrodes in the subthalamus nucleus or in another target, the globus pallidus. This might not mean much to you, but it's another target for deep brain stimulation, and we wanted to look at both because they both are used in the clinic. And so far we found that the networks that are stimulated that go to more frontal brain regions versus the motor, so that associative network in a sense, is linked to less apathy, so basically a slight improvement. So we're hoping that if this continues to show up in a larger sample, that we can test this with stimulation of those networks and see if that helps in terms of feelings of drive and motivation. For the other target, for the globus pallidus, it looked different. It was more so the somatosensory network that was associated with better outcomes. And again, this is currently for each target we have 10 patients, so we'll increase our measurements and see if this holds up, and then we can start stimulation studies and test if this will actually help with better outcomes. We can target these trajectories. Yeah, so again, this can help optimize the overall experience with neuromodulation. Hopefully, if it's not now, in the future, we can get a better outcome that is targeted towards both the motor and the mood and cognition. It's small steps, but it's one puzzle piece in the overall journey. Now, what other neuromodulation techniques are there besides deep brain stimulation? I think I thought this was exciting to look into because there's been so much in the news about vagus nerve stimulation, and I don't know if you have seen or heard anything about it. There's a ton of devices on the market right now, and they all promise basically to put you in heaven, pretty much. They're very optimistic about their effects on wellness, on cognition, on your overall health, which is probably an overpromise. But I thought it was interesting to address some of it here and maybe look into a review and see what do we know about this? What could it do for Parkinson's disease? Can it do something or not? And there's also spinal cord stimulation, invasive and non-invasive spinal cord stimulation. I won't address that today. It could be a whole other topic, and we do have experts at Louisville who are. I'm collaborating with one of them for a pilot trial, but that's basically another talk. And then exercise will also help modulate your brain, so we'll go into that as well. So the vagus nerve is you may have heard of it. It's a large nerve that goes all the way from your gut to your brain. It regulates heart rate, breathing, your vocal cord, and stimulation of the vagus nerve has been very well investigated for epilepsy again. Not the non-invasive as well, but the invasive stimulation, which means again an implanted device that surgeons will put onto somebody's vagus nerve. They implant it. That has worked really well for epilepsy and for depression, and that work has gained a lot of traction and attention. So people became interested in looking at, or scientists became interested in, and companies in how this can benefit other functions beyond those that have been shown. And now there are non-invasive stimulators that, stimulators that basically stimulate the ending of the nerve in the ear. So it's pretty much it looks like a little headset that you can put on. Some of them look very slick. You can put on your ear and it will stimulate the vagus nerve. That's the ending that's right here. And this has been used or is now being investigated for many different things. And I was interested to see what can this mean for Parkinson's disease. Is this a potential additional treatment that you can add on to your medication, or does it even have a benefit? So I looked into a review that just came out. This was a systematic review done by a group in Canada, by a neurologist in Canada. It looked like it has promising effects for the motor outcomes, for gait, and for step length and stride. So that was, I think, very interesting. And this is from the studies, this review was based on studies from the last 10 years or so.
Now, is that still in study, or is that to the market now?
Oh, these devices, there are many on the market.
Oh yeah?
Yes, and you can buy them for $600. Yeah,
Okay.
there are, it's interesting, they're not that expensive anymore. Some are might even be covered by insurance. I don't know the details on the coverage, but it's certainly something to discuss as an additional, with the neurologist, as an additional treatment. There are side effects too, obviously, like with everything, because you're stimulating a nerve, you're stimulating those tracts that are also involved in regulating your voice. So some people their voice changes a little bit, not permanently, it will be temporary, or some people get a little nauseous because it influences your gut. So it is certainly something you don't just want to go ahead with. Do discuss this. And in terms of cognition, the effects were more limited. There are not too many studies that have been done with vagus nerve stimulation. There's some that showed an improvement in executive function, so there's thinking skills that really help you with the working memory adjustments in planning, task switching. There seemed to be also a small side effect on verbal fluency where that did not benefit. It was addictive, but there weren't that many studies. Really, this is based on about 10 studies. So this is definitely something where it needs more studying, I think, to know how does it work for individuals, how does it impact different stages of the disease, how does it interact with medication, with the brain stimulation. But I think it is an interesting and, in a sense, easy way to add on to existing therapies, non-invasive way. Another very easy way to add on to your life is exercise, or easy, I'm saying that, but a good way. It's not necessarily easy, I realize that that's not the case. For exercise, there are many, many studies that have now shown that there are benefits of exercise on cognition and on motor outcomes. So what types of exercise do really work, or what has been shown to work? Usually it's a combination of different things. So it's not just one type of exercise, but it's both a cardiovascular plus a strengthening, plus something that involves your balance, or maybe even a coordination component. So something like dance or tai chi, or something that is engages more than only the cardiovascular or the strengthening. Most studies show that 2 to 3 times a week, anything between 30 to 60 minutes was beneficial. And the longer you do it, the more protective the effects are, in particular on the brain's plasticity, so the ability to adjust and keep your brain, the networks healthy, and basically preventing as much as you can from the effects of Parkinson's disease. And in terms of cognition, again, the executive functions are the ones that benefit most, and there were also some benefits on the ability to focus and to memorize. But those were not as strong as the executive function. That's one that comes out most, and that really has to do most likely with the networks that are that the imaging studies showed are modulated in a good way by the exercise. So to conclude, I think there are many new promising neuromodulation developments, both in the DBS world as well as outside of that or beyond DBS. Probably a combination of different treatments will be the best to really look at your optimal treatment that works best for you in your life, in your the way you go about. And of course, keep asking questions to your neurologist if you have things that you want to address with them. Ask questions about new research, about new devices. If you have doubts about something, or you've heard about something that seems new and exciting but maybe not clear, just ask them and stay active. Yeah.
We're talking about, everybody's different.
Yeah.
And one of the questions I had, well, you were talking about how like the different stimulation. So do they sometimes do more than one stimulation, or they just focus on one area when they do this?
With the brain stimulation?
Yeah.
Yeah, so the devices have the capability to do more than one stimulation. They can, so it depends on what kind of device you would have. So it can stimulate in different regions or in different areas of the brain, but it cannot necessarily stimulate at different frequencies at the same time. So that is limited, and that's definitely something in the future would be helpful if it can do one type of stimulation in one area and another, so it's both spatially and temporally adjusted. But there are some limitations to the devices. Yeah.
I was just curious because we're talking about like different areas of the brain.
Right.
Just wondered about what they were working on.
Yes, I think eventually it would really be beneficial if there is a combination of different frequencies of stimulation plus different locations that would really optimize it, but we're not there yet.
Okay. So probably focusing on what the main, what they had hardest or whatever that is a stumbling block for the person, it sounds like.
Yes, exactly. Yes, they try to address the main issue first and then go from there. Yeah. Yeah. Any other questions? Yeah.
If you've had DBS several years ago, and as they develop these adaptive techniques, is it
Yeah.
possible they can implement them on an existing device?
Yes. Yeah, that is possible. Yeah. I don't know the details with each individual model, and if it would take replacing the leads, because it might have, well, actually it might, yeah, it depends on how long ago.
Yeah.
But the actual programmer, that's, and the ability of the part that, not the battery, but the programmer that's with the battery,
Right.
that is really, has that capability in interaction with an external device. And if the leads are, depending on what kind of leads the person has, they may need to be replaced, but that depends on, yeah. But it's certainly possible, yeah. And it would not, I don't think it would take an entire new surgery.
That may be worth asking about.
Yeah, absolutely, yeah.
For sure.
Yeah, yeah.
Any other questions?
And you can also reach out to me afterwards. I realized I forgot to put my contact information on here, but I did bring cards. I know there's always questions that pop up later, like, oh, but how about that? And, or do you know about this? Or I want to read up on this. So I'm happy to help with that, find information, or direct you to somebody who knows if I don't know. Yeah.
How do you say your name?
My last name or my first name, or both?
Both names.
Yeah. My first name is Nelleke, like Nelly, but then Nelleke. And then the last name is van Wouwe, which is really hard, even in the Netherlands, it's not easy. So it sounds like wow, but then Wouwe. Yeah.
I thought it was Wouwe.
Yeah, well, yes, exactly. I respond to that too. I respond to many variations. It's okay. The students in my lab cannot pronounce my name, so they just say, "Oh, Dr. Nelleke."
That's what I would call you.
Yeah.
Thank you. Oh, no, hold on, we have another question actually.
Is there an age limit for getting DBS?
An age limit? I know that surgeons tend to, and the neurologists tend to be more hesitant, 75 and up. But there's not a hard cutoff. So we had patients, I think 80 or maybe even a little bit older, that were in a good enough shape that they would really benefit from DBS. So I don't think there's a hard cutoff, it's just that they tend to be more careful after a certain age because of the potential risks or maybe other health issues that might